Okay, based on our understanding of this anatomy, we will now discuss the visual field effects. So, believe it or not, visual field effects is a fixed questions or a rule of thumb present in any exam. Like in the previous FRCS2 exam, it appeared like in 2 or 3 questions in the exam. In any clinical ICU exam, it also present, and they ask you to interpret what is this visual field. In FRC of 2 written part, which will be conducted after 6 days, and also any clinical exam, visual field is very essential in any exam. It is very important to know how to interpret it and how to understand it. So if we wanted to divide the visual field effects into 2 main categories, it will be the neurological visual field effects and the glucomatous visual field effects. Starting by the neurological visual field effects, you can divide them, further subdivide them based on where is the lesion, what is the location of the lesion. Is it present in the optic nerve, in the optic chiasm, in the optic tract, lateral geniculate body, optic radiation, or visual cortex? And so let's start by the optic nerve. If there is a lesion involving the optic nerve, what are the possibilities of visual field effects? It could be an enlarged blind spot, or it could be a central scotoma, or a centrocecal scotoma. And by scotoma, we are meaning it's a visual field effect. Diffuse decrease in sensitivity. In optic chiasm, there is lesions which are including the bitemporal hemianopia, junctional scotoma, hemichiasmal defect, or central bitemporal hemianopia. Lesions in the optic tract may cause homonymous hemianopia as well as the lateral geniculate body. As the fibers split on the lateral geniculate body, they will, if the lesion involving the optic radiation, such as tumor or demyelination or infarction, will cause quadrantenopia, contralateral homonymous quadrantenopia. A lesion in the visual cortex can cause different kinds depending on the anatomical location. It can cause homonymous hemianopia with macular sparing, central homonymous hemianopia, or monoocular temporal crescent. So let's start first with the optic nerve. What are the causes of enlarged blind spot? You see, this is the visual field of a patient, and this visual field can show enlargement of the blind spot here, and also present at the pattern standard deviation. You can see this multiple black dots. This represent enlarged blind spot. So what are the causes that may result in enlargement of the blind spot? Well, it can be a lesion in the optic nerve or a lesion in the retina. A lesion in the optic nerve, it could be a papilledema. So basically, the papilledema is enlargement of the optic disc. So this enlargement will cause displacement of the surrounding photoreceptors, leading to a more blind area that the patient cannot perceive. So actually, the enlargement of the blind spot is a negative scotoma. The patient will not be feeling about it. He will not complain about it. So this is very important as well. So not only papilledema, no, there could be also optic disc drusen. They can cause enlarged blind spot. Optic disc coloboma, this should be coloboma. Peripapillary atrophy, as what happens in myopia. Peripapillary myelinated nerve fibers. You see, you remember the first slide? Myelinated nerve fibers will also block the photoreceptors, causing enlargement of the blind spot. It is not only the optic nerve disorders, but also the retinal disorders. There is a famous disease, it's called multiple evanescent white dot syndrome, very common to be asked in the clinical ICU exams. That they ask specifically about it because it will cause enlarged blind spot. So they bring you a scenario of a patient with like 50 or 60-year-old present with white dot syndrome with multiple punctate lesions in the retina. And this patient, they ask, what will be the most common association? So those patients you will usually present also with by enlarged blind spot or idiopathic enlarged blind spot. We will come to that in the uveitis section. So just I wanted to bring your attention to it right now. So those patients will not complain of any positive scotomas. So they will have full field. They will see that everything is okay. They don't report any problems in the vision. So usually, unless this patient have another complaint, you will not be able to detect it. Like if those patients will present usually with headache. Patients with optic disc drusen also will present with headache, and so on. So the visual field defect here is not the presenting symptom. The next lesion or the next visual field defect is the central or paracentral scotoma. So this is the visual field. Again, we will learn how to interpret the visual field very thoroughly in the glaucoma lecture. So basically, this is the center of fixation, and this is the blind spot. What we can see here is that there is a lesion that's occupying the center of fixation. There is this black dots represent that this lesion is showing a less probability of being normal, and this means that there is a loss of the central vision or loss of the central visual field. So what could cause this problem? It could be a lesion in the optic nerve or a lesion of the macula. For the optic nerve, most of lesions can cause this central or paracentral scotoma. So if the patient has hereditary optic neuropathies, such as Leber hereditary optic neuropathies or GER or BER or Dead-Mold syndrome, all those patients can present with hereditary optic neuropathies and central or paracentral scotoma. Toxic patients with toxic optic neuropathy. Why? Those patients with toxic optic neuropathy and the nutritional optic neuropathy, where they have like vitamin deficiency, those patients will, the most bulky part of the optic nerve is the papillomacular bundle, which represent the central vision. So this part will suffer more from the defective nutrition, or will suffer more from the effect of toxins. So those patients will also present with central or paracentral scotoma. Optic neuritis, again, inflammation will result in any kind of visual field defects, but more common to be central or paracentral scotoma, as we are going to see later on. Compressive lesion can also cause central or paracentral scotoma, but it is not a must. It will depend mainly on the direction of the mass and which fibers they are compressing. Normal tension glaucoma also can cause a central or paracentral scotoma. So, but generally speaking, central or paracentral scotoma, it is more of an optic nerve lesion or macular lesion rather than glaucoma. So, glaucoma tend to affect the central vision late. So, central or paracentral scotoma is not common in terms of neurological visual field defects, as well as the acute defects are not common in the neurological field defects. Also, it is not only the optic nerve, but the macula. So different lesions affecting the macula will affect the central visual field, like macular hole, macular scar, macular branch, retinal artery or vein occlusion, and age-related macular degeneration. Okay, so those lesions will cause central or paracentral scotoma. So this is how a patient with a central or paracentral scotoma will present. He will say that I have a problem, a defect in my central vision. Like I see a black hole in the center, like I don't see your face, I don't see your shoulders. So this is how they present it. They present from positive scotoma. So they will be experiencing symptoms because of this visual field defects. This is very important for the scenario. When you are facing scenarios in the exam, you should make up your mind to understand what will be the patient's symptoms and correlate to the visual field defect. If a lesion is involving the central fibers or central visual field, as well as there is enlarged blind spot, so both of them will be connected together, this is what will result in what's called centrocecal scotoma. So centrocecal scotoma, there will be enlarged blind spot, and central and paracentral scotoma, all of them connected together. So this can also be happens to the same reasons that will cause a central scotoma, like hereditary optic neuropathies or toxic optic neuropathy, nutritional optic neuropathy, optic neuritis, compressive lesions, or normal tension glaucoma. Then we will come to the altitudinal field effects. We are still in the optic nerve and retina. So altitudinal field effects, meaning that there is loss of the hemifield. It could be the upper hemifield or the lower hemifield. What are the causes of the altitudinal field effects? The optic nerve, the most important is the ischemic. The ischemic part or the ischemic optic nerve, optic neuropathy will result in altitudinal field loss. It could be upper or lower. Less common causes will be the compressive and the optic neuritis. So compressive and optic neuritis, they tend to be less likely to respect the midline as the ischemic type, but they can still be considered of an altitudinal field effect. More commonly to present with altitudinal field effects will be the retinal causes. Like if there is hemi-retinal artery occlusion or hemi-retinal vein occlusion involving the upper retina or the lower retina, if there is retinal detachment, if there is retinitis pigmentosa or retinoschisis. Those lesions may also present with altitudinal field loss. So those patients will experience that there is an area of the visual field is lost, especially if it is the lower part. Many patients may not notice loss of the upper field, but for the lower field, it will be very noticeable. And for the lower field, meaning that there is involvement of the upper retina or the upper part of the optic disc. So this will result in loss of the hemifield of one eye. Regarding the chiasma, so we cleared the optic nerve visual field effects. So the next part will be the chiasmal defects. So here is the chiasma again. What could be the reasons? First of all, before going to the chiasma, retinal lesions can cause some visual field effects, like if there is bitemporal retinitis pigmentosa. So sorry, we are talking about the binasal field effects now. The binasal defects or binasal hemianopia, it is not very common to be seen, but let me tell you what are the causes. It will be some causes in the retina, like bitemporal retinitis pigmentosa. So they will affect the nasal fibers or the nasal visual field. So you can see here that the nasal visual field is affected in both eyes. And also if there is bitemporal retinoschisis, this will result in binasal hemianopia. So you see, the temporal fibers will result in nasal hemianopia, while the defect in the nasal fibers will result in temporal hemianopia, as we are going to see later on. Also, not only the retina that can cause this defect, but also the some causes related to the chiasma, like if there is compression on the chiasma by internal carotid artery aneurysm, it will compress the temporal aspect of the chiasma, leading to affection of the nasal field. Also, there is an important drug, anticonvulsant drug, that will cause this characteristic visual field effect. This is called the vigabatrin. Vigabatrin. Remember that vigabatrin, vision go bad. Remember that by this mnemonic, vigabatrin, vision go bad. So vigabatrin can cause also binasal hemianopia. And I have already seen, or almost all of these cases that will present with binasal hemianopia because of the vigabatrin. And I saw also a case of internal carotid artery aneurysm and bitemporal retinitis pigmentosa. By the way, also bilateral tilted optic disc may result by binasal hemianopia. So we are all minded about the bitemporal hemianopia, but we tend to forget about the binasal or nasal hemianopia. So I hope that this will give you more idea about the binasal hemianopia. Regarding the bitemporal hemianopia, so bitemporal hemianopia meaning that there is involvement of the temporal field of both eyes, which represent the involvement of the decussating nasal fibers, if we are speaking about the chiasm, or other retinal lesions. So for optic nerve, if there is chiasmal lesion, this chiasmal lesion involving the central part or involving the decussating nasal fibers, this will result in bitemporal hemianopia, as you can see here. Also, optic nerve coloboma can cause the bitemporal hemianopia. Tilted optic disc also can cause bitemporal hemianopia. The same retinal lesions that we discussed earlier, they will cause bitemporal hemianopia if they involve the nasal retina. So if there is nasal retinitis pigmentosa, or if there is binasal retinoschisis, this will result in bitemporal hemianopia. Other diseases that such as bilateral dermatochalasis, so they will cause mechanical block of the temporal visual field, or if there is lateral hooding of the eyelids or the eyebrows, and the ethambutol toxicity. Ethambutol toxicity this is one of the antituberculous drugs, which the toxicity of it may result in optic neuropathy and bitemporal hemianopia. So this is how does it look if the patient has bitemporal hemianopia. Those patients will represent with a series of symptoms that I'm going to tell you in the chiasmal lesions, but basically they will complain of the visual field effects, can complain of difficulty in reading due to various reasons. They can complain of, if the patient is very clever, he may notice that there is a change of the color saturation. And also they may complain of headache, which is unlikely, but it could be also. And they can also complain of the hormonal manifestations for if they have secretory pituitary adenomas. So speaking about the pituitary adenomas, these pituitary adenomas will arise from below the chiasma. So they will compress the chiasma from below. So this will result in compression of the lower nasal fibers, leading to superior visual field effects. So this patient will have bitemporal hemianopia, which is starting superiorly or more dense superiorly. You got it now? So because there will be the compression is starting inferiorly, involving the inferior retinal fibers. So this is very characteristic and very classic for the pituitary adenoma to present with bitemporal hemianopia, which is more dense superiorly. On contrary, the bitemporal hemianopia can start inferiorly. And when this happens with craniopharyngioma. And this craniopharyngioma, starting at the root or at the floor of third ventricle, it will compress the chiasma from above, resulting in compression of the superior nasal fibers, resulting in bitemporal hemianopia that is starting inferiorly. So this, don't just, when you see this picture, don't just think that this is a quadrantenopia, because it is a quadrantenopia if it is a quadrantenopia, or if there is involvement of the parietal or the temporal fibers, they will be contralateral homonymous. Like it will be the right, it will be present like this, here, and here. So this will be contralateral or right homonymous hemianopia. So homonymous meaning that it will be on the same side. This case is not homonymous. So this doesn't represent, or this is not a lesion in the parietal or the temporal radiation. Okay, this is just a bitemporal hemianopia that you caught it early, so you saw it before it become full-blown bitemporal hemianopia. And by the way, the full-blown bitemporal hemianopia is not very common. So unlike the classic teaching where we think always of a bitemporal hemianopia in any case of pituitary adenoma or a chiasmal disease, no, it doesn't always have to be a bitemporal hemianopia, rather than it will be more dense superiorly or more dense inferiorly. Then we will check for there is other variants of the chiasmal compression, like junctional scotoma that I was just speaking about. If there is a lesion which is involving the chiasm at the junction between the chiasm and the optic nerve, where there will be the decussating fibers of the superior nasal fibers. So the inferior nasal fibers. So this will represent the anterior knee of Fulbrand. So what happens if there is lesion involving the junction between the chiasm and the optic nerve? Well, this will result in loss of vision in one eye. This is a clinical scenario that appeared in the clinical ICU exams before. So just concentrate. When there is a lesion involving the optic nerve, there will be loss of vision in one eye, and there is involvement of the inferior nasal fibers, which are decussating from the other eye. So this inferior nasal fibers will be responsible for the superior field. So there will be affection of the contralateral superior visual field, like this. So there will be involvement of the left eye, or there will be loss of vision of the left eye, and involvement of the superior visual field of the contralateral eye or of the right eye. So this is what's meant by junctional scotoma. This patient has junctional scotoma. So when you see this pattern of visual field defect, you think, or you know, that the lesion is presenting at the anterior knee of Fulbrand or anterior knee of Fulbrand. This means that this is a lesion at the junction between the optic chiasm and the optic nerve. Dr. Ramya, we will come to that. We will just bear with me for 2 slides, and we will tell what is the congruous and the incongruous. Regarding the optic chiasm, so the optic chiasm also can present with other variety of lesions. It can be present with the central bitemporal hemianopia. This is the central bitemporal hemianopia. You can see this is a lesion involving the posterior part. This also appeared in the advanced ICO exam before. If there is a lesion involving the posterior part of the chiasm, this is where the macular fibers are decussating. So the macular fibers decussating posterior in the chiasm. If the lesion is involving the posterior fibers alone, this will result in bitemporal hemianopia, which is only central. Only central, small bitemporal hemianopia involving the central field, the temporal aspect of the central field of both eyes. This means that it is a central lesion involving the posterior part of the chiasma. Okay, so this is what's meant by central bitemporal hemianopia. After that, the optic tract. So if a lesion involving the optic tract, what will it cause? The optic tract, as we agreed, it carry the ipsilateral temporal fibers and the contralateral nasal fibers. So if there is a lesion involving the optic tract, the right optic tract, it will involve the right temporal fibers and the decussating left nasal fibers. Okay, so it will go, if a lesion also on the other side, if it is involving the left optic tract, so it will involve the ipsilateral temporal fibers, and ipsilateral temporal fibers is the left ipsilateral temporal fibers, resulting in nasal field defect. And it will involve the contralateral nasal fibers, which are decussating. The contralateral nasal fibers from the right eye will be responsible for the temporal field. So it will resulting in temporal field defect of the right eye. So a lesion in the optic tract will lead to hemifield defect, vertical hemifield defect in each eye. Since we are speaking about the left, and the left optic tract, and you can see that the visual field defect here is involving the right aspect of the right eye, or right hemifield of the right eye, and right hemifield of the left eye. So this is called right homonymous hemianopia, because it is involving the right hemifield of the right eye and right hemifield of the left eye. And this patient has left optic tract lesion. So a left optic tract lesion will cause right homonymous hemianopia. Right or contralateral, homonymous, meaning that it is in both of the right aspect. Hemianopia is meaning that it is hemi is half, opia is vision. So they have hemifield visual field effects involving both eyes to the right side, and they will respect the midline. So here we have a term that is called the congruity. The congruity meaning that when the lesion is retrochiasmal, or after if there is like a tumor or any mass or any lesion involving the optic tract or visual radiation or the occipital cortex, we have a clue about the anatomical location of this lesion. Meaning that if the lesion is more anterior, like if it is immediately posterior to the chiasm, or if it is more posterior, like it is more close to the lateral geniculate body or more posterior. If the lesion is more anterior, it is more incongruous. If the lesion is more posterior, it is more congruous. What is meant by congruous and incongruous? Congruous meaning that it is symmetrical or similar. The both lesions of both eyes are similar. So here you can see that the lesion of the right eye is almost identical to the left eye. This is what is meant by congruous. So the lesions here is congruous. So I'm expecting that the lesion is far posterior. It is retrochiasmal because it is it is contralateral homonymous hemianopia, and it is more posterior because it is more congruous. But a check here for this patient. This patient has contralateral or has left homonymous hemianopia. However, the lesion is not symmetrical. It is not identical. So it is more incongruous. It is more incongruous, meaning that the lesions are not similar or doesn't follow the same pattern or same shape of the density and the location of the scotoma. So this means that the lesion is more anterior. Okay. So this patient, you can see this patient has left homonymous hemianopia. He cannot see the vertical, or he cannot see the left hemifield of both eyes. Okay, clear now? Now let's check for the lesions in the lateral geniculate body. Lateral geniculate body will have also the right lateral geniculate body will have the temporal ipsilateral temporal fibers and the contralateral nasal fibers. So if there is lesion involving the lateral geniculate body, it will also present with a contralateral homonymous hemianopia. You can see that it is more congruous because we are more posterior. So when I see this, I expect that this patient have more posterior. It could be a lesion in the optic tract or lateral geniculate body, but is more posterior. So I'm thinking if it is more in the posterior tract or in the lateral geniculate body because of the congruity of the lesion. Okay, to summarize the visual field defects present at this location. So number one, if there is lesion involving the optic nerve, it will result in total loss of vision or total loss of visual field, depending on how much optic nerve fibers are involved. If there is lesion which is involving the junction between the optic nerve and the chiasm, it will result in junctional scotoma. So if this is the right eye, this will result in loss of vision in the right eye and involvement or loss of visual field of the right eye and involvement of the decussating inferior nasal fibers from the left eye, which will be represented by superior visual field defects of the other eye. This is called a junctional scotoma. Number three, if there is lesion involving the chiasm, it will result in bitemporal hemianopia. And if this lesion is involving the chiasm from below, it will result in a bitemporal hemianopia, which is more denser superiorly as in pituitary adenoma. Or if the lesion is involving the chiasma from above, this will result in bitemporal hemianopia, which is more dense inferiorly, which is as like in craniopharyngioma. If there is lesion involving the chiasma from posterior, this will resulting in involvement of the decussating macular fibers, resulting in central bitemporal hemianopia. And if there is lesion involving the optic tract, it will involve the ipsilateral optic tract temporal fibers and the decussating nasal fibers from the other eye, like this. You can see this is the ipsilateral optic tract fibers and the decussating nasal fibers from the other eye, resulting in incongruous. So you can see that this incongruity is not symmetrical or not identical. Contralateral homonymous hemianopia. Okay. After that, the visual fibers will split, as we said. They will split into two kinds of radiations: the temporal radiation and parietal radiation. So each one of them will carry only, since the optic tract will carry half of the fibers, it will carry only the ipsilateral temporal fibers and the contralateral nasal fibers. So if they further split, each radiation will carry only quarter of the fibers. So involvement of the radiation will only involve a quarter of the visual field, or quadrantenopia. So if the patient has involvement of the temporal radiation, this temporal radiation will involve the inferior retinal fibers, which will be responsible for the upper visual field. So this will result in contralateral homonymous upper quadrantenopia. This is for involvement of the temporal radiation. If there is involvement of the parietal radiations will carry the superior retinal fibers, which will be responsible for the lower visual field, as we can see in this patient. So this will result in contralateral lower quadrantenopia. And see, this patient has contralateral homonymous right quadrantenopia. So the lesion here is on the left. Left what? Left temporal or parietal? Well, here it is lower. So the lesion is in the parietal radiation. We got it now? An easy way to remember it is remember this mnemonic. I always say it in my lectures. So remember T for tall and P for pit. So T for tall, representing for the upper radiation or the upper scotomas, the what's called a pie in the sky. If there is superior scotomas or it is tall, it is due to temporal lesion. If it is a lower lesion or a lower scotoma, such as we can see here, it is called the pit, or it is in the pit, it is below. So this will be responsible by parietal radiation. So T temporal tall, P parietal pit. So this will be if you are just confused about which one will cause which visual field defect. Okay, so this is in respect to the quadrantenopia and the radiations, optic radiation, and the temporal and the parietal radiation. So let's move now to the next kind of visual field effects. So here we come finally to our final destination, which is the occipital cortex. So the occipital cortex can cause a variety of lesions or visual field defects depending on what is the lesion is involved, or what is the where is the location of the lesion. It could be a homonymous hemianopia with macular sparing. Like if there is this mainly occurs with occipital lobe lesions with that involve the occipital lobe like posterior cerebral artery occlusion. If there is occlusion of the posterior cerebral artery, the central part of the macula or the central part of the occipital cortex representing the macular fibers, it will be still supplied by branches from the middle cerebral artery. So it will result in contralateral homonymous hemianopia with macular sparing. This means that the central vision is still preserved, as the lesion is only involving the posterior cerebral artery with intact or preserved middle cerebral artery. Also, if there is lesion only not involving the occipital cortex as a whole, but just involving the tip, only the tip of the occipital cortex, this will result in central homonymous hemianopia, because it will only involve the central fibers. You remember the posterior lesions in the chiasma causing central bitemporal hemianopia? The same thing here. Lesions involving the central part of the occipital lobe will only involve the macular fibers. So they will only involve the central visual field. They will only cause central by homonymous hemianopia. So this is a patient with a lesion affecting the tip of the occipital cortex, causing contralateral homonymous central hemianopia, while this patient has homonymous hemianopia with macular sparing as with posterior cerebral artery occlusion, as we mentioned in the first the previous slide. Another characteristic lesion which occurs in case of occipital cortex is the monoocular temporal crescent. So a patient, all this is like will be the exception of a rule. So what is the rule? The rule is any retrochiasmal lesion will cause bitemporal or will cause bilateral visual field effects. Again, the rule is any retrochiasmal lesion, when you see a patient, neurological patient with bilateral visual field effects, you expect that the lesions is retrochiasmal or orthochiasmal, except if the patient has monoocular temporal crescent. In this case, it will be a unilateral lesion. However, it will be retrochiasmal. So what will be the reason behind this monoocular temporal crescent? This lesion involves the far temporal periphery of the ipsilateral eye only. So if there is involvement of the right eye, there will be involvement of the right temporal 30 degrees, only the temporal 30 degrees. So the temporal 30 degrees of binocular visual field actually is perceived by the nasal most retina of the ipsilateral eye only. So this patient, this is the right temporal field. This is represented by the nasal retina of the right eye, okay? The far periphery of the nasal retina. And these lesions, this nasal retina, the most nasal retina, are represented in the most anterior part of the occipital cortex, like here. So what happens if there is lesion in the most anterior part of the occipital lobe? This will result in involvement of the far nasal fibers or peripheral nasal fibers. And this peripheral nasal fibers will be represented by the temporal field, by the far temporal field. And this will result in affection of the far temporal periphery of the contralateral eye. And that's why it's called the temporal crescent. It will cause a far temporal periphery of the other eye, resulting in appearance of a crescent. Like, let's say an example, if there is a right anterior occipital lobe lesion, this right anterior occipital lobe lesion will cause a far temporal visual field in the left eye. So this patient will have left monoocular temporal crescent. And vice versa, if there is right occipital lobe lesion, this will result in left temporal monoocular crescent. So this will depend mainly where is the lesion. The lesion is involving the most anterior part of the occipital cortex. The final visual field effects will be the constriction of the visual field. If a patient is presenting with progressive constriction of the visual field, it could be could be the causes. So you can see that this patient has only central field. This is a central visual field, and the patient only has preserved central vision. So this will be 4 P's. There are 4 P's, 4 important P's. The papilledema, late stage. So papilledema in early stages doesn't affect the visual field, but in late stages can cause optic atrophy and it can cause constriction of the visual field. Primary open angle glaucoma, of course. So the glaucomatous visual field effects will be discussed in the glaucoma, and you can see that it will present with normal visual field initially. It can be present with enlarged blind spot, nasal step, arcotoscotoma, constricted visual field. All this can be the end stage of primary open angle glaucoma. Retinitis pigmentosa, pan-retinal photocoagulation also are common causes of constricted visual field. So for those patients with constricted visual field, they will report that they will show a progressive decrease or constriction of the peripheral field. So they will look through to the world as if they are looking through a keyhole. So they are as if they are having tubular vision, or what's called the tunnel vision. This will be the end result of the visual field effects, or the end result of the progressive narrowing of the peripheral visual field and progressive constriction of the peripheral visual field. Okay. So this is all we need to know about the visual field effects. I hope that this is clear. Does anyone have any questions so far?